Very good morning to all. I am Dr. Priya, Associate Professor from the Department of Periodontology, Vinayaka Mission Sankaracharya Dental College. Today, I am going to take class on periodontal regeneration and reconstructive surgery. And I will be discussing on the following contents: introduction, outcomes of reconstructive periodontal surgery, regenerative periodontal techniques, classification of bone grafts, properties of ideal bone graft, and all the bone grafts in detail, bone grafting technique, and finally the conclusion. Now let's go into the class. When periodontitis occurs, there is formation of pocket, there is degeneration of cementum, destruction of periodontal ligament, and bone loss. So we do periodontal surgery to regain the lost attachment apparatus. So reconstructive periodontal surgery is nothing but a surgery that aims at re-establishing the lost attachment apparatus. Let's go into certain terminologies before going to the details. What is regeneration? That is the ultimate goal of any periodontal therapy. Regeneration is the natural renewal of a structure produced by the growth and differentiation of new cells and intercellular substances to form new tissues or parts. Then what is repair? It is nothing but healing, but without the complete restoration of the architecture and the function. So healing takes place but with the formation of a scar tissue. What is new attachment? New attachment is the embedding of the new periodontal ligament fibers into new cementum and the attachment of the gingival epithelium to a tooth surface that is already affected by a disease. Then what is reattachment? Reattachment refers to repair in areas of the root that is not previously exposed to the pocket, such as after surgical detachment of the tissues or following traumatic tears of the cementum, tooth fractures, or treatment of the periapical lesions. So after any periodontal surgery, what are the possible outcomes of this reconstructive surgery? The following types of healing takes place either by new attachment, long junctional epithelium, root resorption or ankylosis, recurrence of pocket, or any combination of the above results. You can see the diagram here. This tooth is affected by the periodontal disease where you can see apical migration of the junctional epithelium, so there is pocket formation, there is defect in the cementum, affected periodontal ligament, as well as there is bone loss. So when we do a periodontal surgery, these are the different types of the healing which takes place. Either it heals by new attachment, long junctional epithelium, root resorption or ankylosis, recurrence of pocket, or combination of the above. So how do we do this regenerative techniques? Either by use of bone graft associated procedures or non-bone graft associated procedures like using guided tissue regeneration membrane, LANAP, or root biomodification, or recent advances like growth factors, stem cells, and tissue engineering too. So today I am going to talk in detail about bone grafts. What is a bone graft? It is nothing but a viable material which can be natural, artificial, or synthetic that is placed in the areas where there is bone loss affected because of the periodontal defects. So what all areas we see the bone loss? In periodontal defects, intra-bony defects like single wall defect, two wall defect, three wall defect, furcation defects, here all there is bone loss, so there is a necessity to place the bone grafts. And in areas where you have to place implants, if there is insufficient bone, definitely we need bone grafts. Sinus elevation procedures, ridge augmentation techniques. So these areas there is loss of the bone, so we need to place a material which might help in the regeneration of new bone. So what are the objectives of periodontal bone grafts? As I told earlier, because of periodontal disease, there is pocket formation, attachment loss, bone loss, and all. So we have to regain all these things. So any bone graft that should help in reduction of the probing depth, clinical attachment gain, and good sufficient bone fill, and it should help in the regeneration of new bone, cementum, and periodontal ligament. So let's go into the classification of these bone grafts. How the bone grafts are classified? They are classified based on the origin as autografts, allografts, xenografts, and alloplasts. See the diagram here. This is autograft, that is grafts transferred from within the same individual from one position to another. Suppose if I have a defect in the right area, I may take a graft in the left area and place it in the right. So grafts that is transferred within the same individual from one position to another is called as autograft. Then what is allograft? Allograft is nothing but the grafts which is transferred from different individuals but same species. Then something called as xenograft, that is the grafts which is taken from a different species. Then alloplast is nothing but synthetic or artificial materials. The 4 types of bone grafts are autograft, allograft, xenograft and alloplast. So how do these bone grafts work? They should have a certain principle to work. So basically the bone grafts, they work under the principle of osteogenesis, osteoinduction or osteoconduction. What is osteogenesis? The bone forming cells are called the osteoblast. So osteogenesis is a process in which the cells which are contained in the graft, they have the ability to produce osteoblasts that help in the regeneration of new bone. What is osteoinduction then? Osteoinduction is nothing but a chemical process by which the cells contained in the graft, they convert the neighboring cells into osteoblasts that will help in regeneration of new bone. Then what is osteoconduction? It is nothing but a physical effect by which the matrix of the graft forms a scaffold and it favors and attracts outside cells to come and penetrate the graft, and that will help in the formation of new bone. So osteogenesis, osteoinduction and osteoconduction. So these are the principles by which all the bone grafts work. So we cannot place any material as a bone graft. It has to fill certain criteria. So what are the properties of ideal bone graft? They should be non-toxic, non-carcinogenic, easily available, biocompatible, good predictable, should not cause any infections, minimal preoperative and postoperative hazards, should give adequate bone full, then cost effective and easily accessible to the patient. So these are the ideal requirements of any bone graft. So now let's go into the details of all the bone grafts. Autografts, as I told earlier, the grafts which is transferred within the same individual from one position to another is called as autografts. The graft might comprise either of cortical bone or cancellous bone, and 2 sources are, it can be either taken from intraoral source or extraoral source. So what are the bone from the intraoral sites, the sources? It can be taken from edentulous areas of the jaw, healing extraction sites, maxillary tuberosity, mandibular retromolar area, bone which is removed during the osteoplasty and ostectomy techniques, and mandibular symphysis menti. So these are the sources from the intraoral sites. So what are the types of the autografts? There are 4 types basically: osseous coagulum, bone blend, cancellous bone marrow transplant and bone swagging. We remove certain bones during the osteoplasty and ostectomy techniques with the help of any rongeurs or hand chisels. Even that is called as cortical bone shavings, that can be used in place of defects or increase the bone height. But the disadvantage is because it's got larger particles, always leads to sequestration. So it is not very effective in giving the regeneration. The next is called as the osseous coagulum. The name itself indicates osseous coagulum, the mixture of bone dust and a patient's own blood. So this technique uses small ground particles with the blood, and it is placed in the defect. The bone is removed with a carbide burr 6 or 8 at the speed of about 5,000 to 30,000 rpm. It is placed in a sterile tapen dish and it is placed in the defect. The sources basically are exostosis and edentulous ridges. The advantages is because it is ground particles, bone dust, it provides additional space for the interaction of the other cellular elements, and better resorption and replacement with the new bone takes place. The disadvantages is you can procure only smaller particles, so it cannot be used for larger defects. It can be used only for a smaller defects, and inability to use aspiration also, it is important. So we should not, these are the 2 disadvantages of this osseous coagulum, but it's very predictable. There's something called as bone blend, blending the bone. What is that? It's a technique which uses autoclaved plastic capsule and pestle. The bone is removed from a predetermined site with a trephine or rongeurs and triturated in the capsule to a workable mass and then placed in the defect. Then what is cancellous bone marrow transplants? The sources basically are maxillary tuberosity, edentulous areas and healing extraction sockets. The maxillary tuberosity contains good amount of cancellous bone. The cortical bone is very helpful in maintaining the structure and the framework. The cancellous bone has got a very good potential of more amount of osteoblast. So this gives a better regenerative potential. So either in maxillary tuberosity or edentulous area, an incision is made. Incision is made and the flap is reflected and the bone is removed either using curettes back action chisels or trephine. You can see in the diagram the bone particles either with the use of the back action chisels or a trephine burr. It is removed, it is placed in the tapeworm dish, mixed with saline and the blood and then placed in the defect. This is bone marrow cancellous. Another technique is called as the bone swagging technique. This was introduced in in 1965. This technique uses edentulous area adjacent to the defect. There should be an edentulous area adjacent to the defect. From there, the bone is pushed in contact with the root surface. But the very technical difficult because there are chances of fracturing the bone, and this technique is no longer used. So these are the sites for the intraoral as well as the intraoral sites technique. Now bone is also taken from the extraoral sites. That is, sources are iliac crust marrow, ribs, cranium and tibia metaphysis. See, when we take the bone graft from an extraoral site, naturally we can pick a larger amount. But the disadvantage is because it requires a second operational site there, post-operative infection might be more, it might result in ankylosis and root resorption and patient discomfort. For periodontal defects, only the intraoral site is preferred and extraoral site is not preferred. So this is all about autografts, and autografts are considered to be the gold standard because it is the only graft which has got the osteogenetic potential, more amount of osteoblast. So a predictable regeneration is effective in this case. Let's move on to the next one, that is the allografts. That is grafts transferred between different individuals of the same species. Then the types are frozen iliac cancellous bone marrow, freeze-dried bone allograft, demineralized freeze-dried bone allograft. So among these three, the frozen iliac cancellous is no longer used due to certain reasons. See, even though it is taken from the same species, it's different individuals, so there is chances of disease transfer, graft rejection and other possibilities. So to devoid of all these things, the grafts which are obtained, they have to undergo certain processes like chemical processing, radiation and freezing to get devoid of all the disease transfer. The bones cannot be taken from everybody. The donors cannot be everyone. High risk patients, syphilis patients, patients with AIDS, from these the bone is not taken. And there are commercially available banks, tissue banks, which follow certain criteria and guidelines for storing the bone grafts. The cortical bone graft, cortical bone is obtained in a sterile manner within 12 hours of the death of the donor, and this is preferred over the cancellous bone because it is less antigenic and contains more bone inductive proteins. Then after procuring it, this bone is cut into 0.5 to 5 mm particle size. It is immersed in 100% ethyl alcohol for 1 hour. So within this time, the bacteria and the viruses are it's all gone. So it is free of all the bacteria and the viruses. And then it is frozen. Then again it is ground to more finer particles of various sizes and stored. Then again it is immersed in alcohol and then it is freeze dried. Further, it may or may not be demineralized. So what is this freeze dried bone allograft? Getting all the procedures, it is freezed at a certain temperature. Because why it is freezed? It is freezing the graft loses the cell viability, therefore it promotes the bone regeneration through osteoconduction, and the antigenicity also is reduced. Then how do we demineralize? Further, it is demineralized with cold diluted 0.6 N hydrochloric acid for 6 to 12 hours. So by doing this procedure, this exposes something called as bone inductive proteins, the bone morphogenetic proteins which is present in our body. They play a very important role in angiogenesis, wound healing, etc. So these proteins have the ability to stimulate the host cells, stem cells, to differentiate into osteoblasts. They are the bone forming cells. So they are considered to be inductive in nature. So demineralized freeze-dried bone allograft is the only graft which is osteoinductive in nature. The other allografts are osteoconductive in nature. There are so many commercially available products of this allograft, which in the powder form or putty form or a gel form. So it is available in different forms and you can procure larger amounts. Autograft and allograft together can be mixed in a combination technique and placed in the periodontal defects to achieve better results. Let's move on to the next one, that is the xenografts. Xenografts are nothing but the grafts which are taken from the donor of a different species, mostly taken from bovine and porcine, because they are more biocompatible and structurally they are quite similar to bone, human bone, and they are osteoconductive in nature. Mostly bovine derived is taken. We take the bone from the bovine and The organic component is removed, retaining the inorganic component. So the porosity and the trabecular structure, it is maintained. Either calf bone or keel bone, that is nothing but the calf on the ox bone, is taken. It undergoes deproteination, treated by extraction, sterilization, freeze-dried and then used. But nowadays this calf bone and keel bone, they are not used because due to certain reasons of antigenicity and so all the other factors, these two are not used. Currently, an organic bovine derived graft, which is supposed to be osteoconductive in nature, taken from bovine, either cancellous or the cortical bone, is used. It is marketed under the name of BioOs. Here again, the organic components are removed, retaining the inorganic component, maintaining the trabecular architecture and the porosity. So this permits the clot stabilization and helps in revascularization and better regeneration. So it is marketed in the name of BioOs. This BioOs in combination, this is a BioOs which is marketed in the market, trade name is BioOs. When this BioOs is in combination with a cell binding polypeptide which is marketed as P15, called as a peptide gel P15, this both together enhances the regeneration to better, more effectively. So, but this xenografts usually takes about 6 to 18 months for bone resorption and form a new bone. So, this is all about xenografts. Now, let's move on to the next one, alloplast. These are nothing but the synthetic, inorganic, biocompatible or bioactive bone graft substitutes which promote bone healing through osteoconduction. This is a nice artificial or synthetic material. This can be available in different forms like powder or putty form, variable density, variable sizes, porosity and crystallinity depending upon the manufacturing process. These materials, they degrade either by solution mediated resorption or by cell mediated resorption. This usually takes a longer time compared to the autograft, allograft and the xenograft, ranging from 6 months to 24 months. Some are resorbable, some are non-resorbable. Some materials are osteoconduction and mostly others, they only act as a fillers, filling the space, thereby preventing the progression of the disease further. What were the materials used at the alloplast? In earlier days, previously, sclera, cartilage and plaster of Paris were used, but nowadays they are not in use. Recently, polymers, bioceramics and bioactive glasses are used nowadays. What are polymers? HTR. It is called as hard tissue replacement polymer. That is a synthetic. It's not a resorbable but a non-resorbable biocompatible microporous composite of polymethyl methacrylate and polyhydroxyl ethyl methacrylate with a calcium hydroxide coating. Even though it is a non-resorbable bone graft, it is biocompatible. For giving the good framework, this can be used. This particle is manufactured with the size of about 315 mm and a central pore which is used to facilitate the ingrowth of the bone. The next one which is used is, this is the one which is commercially available polymer that is called as a bioplant. The next one is bioceramics. They are comprised primarily of the calcium phosphate. Calcium phosphate biomaterials have excellent tissue compatibility and did not cause any inflammation or foreign body response. So they are very, very biocompatible and extensively used. Two types of bioceramics are used in recent times, namely tricalcium phosphate, which is non-bioresorbable, and hydroxyapatite crystals, as we all know, that is partially bioresorbable. The next one is bioactive glass. Bioactive glass is nothing but a synthetic material which is biocompatible, composed of sodium and calcium salts, phosphates and silicon dioxide. When this bioactive glass is exposed to tissue fluids, the surface of the particles they become coated with hydroxycarbonate apatite. This incorporates the organic ground proteins such as chondroitin sulfate and glycosaminoglycans, and this attracts the osteoblasts and rapidly help in the formation of the new bone and help in the regeneration. And the two commercially available products are named as the Perioglass and the Biograin. The one advantage of this Alloplast is because they are synthetic and artificial, larger amounts can be procured and their cost wise they are less cost comparative to the other bone grafts. So these are about the bone grafts. So we all saw about what is autograft, what is allograft, what is xenograft and what is alloplast. Now, how do we place these bone grafts in the defect? What is the bone grafting technique? How do we do it? First, a thorough proper case is to be taken and a proper treatment planning is very, very essential before going to the treatment. And all the pre-surgical procedures should be undergone. Scaling and root planning should be done and if any occlusal adjustment that has to be taken, if there is any mobility, stabilize the tooth with the help of the splitting, wait until the initial healing has taken place and then go for the periodontal flap surgery. Then a proper flap designing for a complete closure is very, very essential. So the ideal flap for the bone grafting technique is full thickness flaps with the papilla preservation flap is the ideal technique for the bone grafting technique, because that ensures complete coverage of the interdental papilla after suturing. So there is no spillage of the bone graft. So papilla preservation flap is the ideal technique for the bone grafting procedure. So after administration of LA, using a BP blade, the reflection of the flap is done. After reflecting the flap, all the curettage and the root planning is done. The degranulation tissue is removed, all the tissue tags, the remnants and all are removed. The root is planed, and after that, the root biomodification is done by using certain agents like citric acid or tetracycline, fibronectin, enamel matrix derivative, etc. because they remove the smear layer, expose the dentinal tubules and help in the better attachment of the root and more acceptable for healing. So after the curettage, after degranulation tissue, after irrigation, root preparation is done. That is the root, we're using the root biomodifying agents. So all these procedures are done. Now coming to the placement of the bone grafts. Before the placement of the bone grafts, pre-suturing has to be done, because once you place a bone graft and then you go for a suturing, there is a possibility of dislodgement of the bone grafts. So we should not place the bone grafts and then go for a suturing. First, pre-suturing, there is loose placement of sutures which is left untied prior to the filling of the defect is very, very essential. Then after pre-suturing, now the bone grafts are taken, placed in a dampened dish, it's mixed with the saline and the blood and then to a workable mass and then placed in the defect area and then condensed well. See, you can see in the diagram, it is placed in the defect area and then condensed well. So it has to be ideally filled to the realistic level, no underfilling and no overfilling. So condensed well. Then after this, you can place either a GTR membrane depending upon the defect necessity. So complete the bone grafting procedure and then place the flap appropriate position, proper position, and then complete coverage should be done. Suture it so that complete coverage is essential. Now the grafting procedure is over, then give a periodontal dressing. Why a periodontal dressing is given? Because you have placed a bone graft. So avoid the flap displacement as well as the losing of the graft material and as well as to protect that area from any foreign materials or injury, we place a periodontal dressing. And then a good antibiotic coverage and analgesics and post-operative instructions should be given to the patient as so as to follow. So this is about the bone grafting technique. So in today's class, we saw what is reconstructive periodontal surgeries, what is regeneration, repair, new attachment and all the other procedures. How do we use the regenerative techniques by using of the bone grafts? What is a bone graft? What is the principle behind the bone grafting? Classification of bone grafts, ideal requirements of the bone grafts, and each and every bone graft in detail, and the commercial level products, and how do we do the bone grafting techniques. Finally, I would like to conclude this. The ultimate goal of any periodontal therapy is regeneration. So this regeneration is achieved by using bone grafts wherever there is bone loss with the help of the bone grafts as well as non-bone grafting procedures also to achieve the regeneration. This can be used either allo or in combination also. Many studies have shown that combination techniques with the bone grafts as well as bone grafting techniques, mixture of either autografts, allografts or other grafts along with the GTR membranes give good predictable results. Today is a modern world and so many new materials are being produced every day, introduced to the market every day. So in advanced techniques in future, we can expect more bone grafts to be coming to the market, and with the help of the stem cells and tissue engineering, so we can take this to the periodontal regeneration results to be more predictable in nature. So this is all about the class. Thank you for listening and watching to my class.